Hello everyone, welcome to the case-based learning session in toxicology. In this session, we are going to deal with iron toxicity. We will be discussing two cases and based on that, we will be learning about iron toxicity. Alright, let's begin, shall we? Okay, case 1 is a 22-year-old girl who allegedly ingested more than 200 tablets of ferrous sulfate. She had abdominal pain and vomiting and she was taken to a local hospital. There they had given her gastric lavage and she was admitted there. She was referred to our hospital 24 hours later because of altered lab parameters. When she came, her vitals were luckily within the normal range, but her liver enzymes had skyrocketed. Her creatinine was elevated. When we did a blood gas analysis, her bicarbonate was on the lower side, suggestive of metabolic acidosis. She was having high anion gap metabolic acidosis and with elevated lactates. We sent blood for serum iron concentration as well as total iron binding capacity. Now, we started her on chelation therapy with Deferoxamine, but after 24 hours in the ICU, the patient developed severe GI bleed. Her blood hemoglobin level dropped from more than 13 to around 7. Her INR was elevated to around 9 and she was having severe metabolic acidosis. So we intubated her, connected to the ventilator and started her on aggressive transfusion therapy with PRBC as well as FFP. We gave her vitamin K as well. She was put on hemodialysis for controlling the severe metabolic acidosis. But despite all these therapies, unfortunately, she died after 36 hours of admission. Now, case 2 is a 17-year-old girl weighing around 60 kilograms. She had allegedly ingested around 100 tablets of ferrous sulfate and this happened around 4 hours back. Now she is having hematemesis and she is actively vomiting. When she came to us, she was slightly tachycardic. Her blood pressure was quite normal. So we did the labs on her. Most of the investigations were normal here. But the ABG showed that there was metabolic acidosis. Alright. So we did an X-ray abdomen on her, which showed that there was still iron tablets inside her GI tract. So we proceeded with a whole bowel irrigation. And we also started her on chelation therapy. She was admitted to the ICU. She had mild hypotension in the ICU, which we supported her with fluids as well as pressors. But after 16 hours of admission in the ICU and after 16 hours of chelation therapy, her blood pressure improved and we could wean her off the pressors, and the next day we were able to shift her to a ward room. Alright. So those were the two cases. And let's see them in detail to learn about iron toxicity. Now in case 1, now you can see that in both these cases I have mentioned the kind of preparation which they have taken, which is ferrous sulfate. So what are the different iron preparations that are available to us? The most common ones are ferrous fumarate here, then ferrous sulfate and ferrous gluconate. Alright, the most common preparation which is available in our markets are ferrous sulfate. Okay, now you can see that in this table the dose of ferrous sulfate in each of the tablet is around 325 milligram. But if you look at the tablets which are available to us, it's around 200 milligram. Now the more important thing than the dosage of ferrous sulfate is the presence or the amount of elemental iron contained in each of these tablets, because the total elemental iron ingestion that has been taken will determine whether the patient is likely to have toxicity or not and how severe the toxicity is going to be. Alright, now in 325 milligram tablets they usually have 1/5 of elemental iron. So in 325 they usually say that there will be around 65 milligram of elemental iron. But if you look at the tablets which are available for us, which is 200 milligram, even that also contains 65 milligram per tablet of elemental iron. Okay. So if you are in doubt, look at the tablets and look at how much elemental iron each of these tablets are containing. Alright. Now the other most important thing which I have mentioned is the total amount of elemental iron they have taken, and I have also mentioned the dose per kg. Why this is important? This is important because if the patient has taken less than 20 milligram per kilogram of elemental iron, toxicity is less likely. Now, if she has taken more than 20 to 60 milligram per kg of iron, it can result in toxicity. This usually results in a moderate toxicity. Now, what if the patient has taken more than 60 milligram per kilogram? Okay, then it can result in severe toxicity with very high mortality. Okay, so that's the importance of knowing how many tablets the patient has taken, what kind of preparation the patient has taken, and what is the elemental iron present in each of these tablets. Alright, now knowing the weight of the patient is also going to be important, right? For example, if this patient's weight I have mentioned as 50 kg, so the toxic dose will be 50 into 20. Alright, that's around 1000. Of course, that's 1000. Okay, 1000 milligram or 1 gram. So this patient has taken 200 tablets of ferrous sulfate, which contains 65 milligram of elemental iron each, right? So 65, so the total dose she has taken is 65 into 200. Okay, so this comes to 130.00. All right, this comes to 13 gram, right? Okay, so she has taken a huge dosing here, and if you look at it, it comes definitely more than 60 milligram per kilogram, right? Now let's see about the clinical features of iron toxicity. Classically, it has been described that there can be 5 stages through which the patient can go, any patient with iron toxicity. Now, stage 1 is usually GI symptoms. So here the patient usually have nausea, vomiting, diarrhea, and abdominal pain. Alright. Now in some severe cases, the patient can even have hematemesis in the initial stage itself. Alright. This is because any metal like iron or lead highly corrosive to the GI mucosa, and they can themselves cause irritation of the GI mucosa and can cause injury there, resulting in hematemesis. Another mechanism of hematemesis could be because of the mammillary venous tears that can occur because of severe retching. Alright. Now stage 2. So stage 1 usually happens within 6 hours. Alright. Now in stage 2, usually the symptoms of stage 1 subsides. So the vomiting gets subsided, the patient's abdominal pain might get subsided, but the patient will appear much more sicker because the patient will go into a stage of metabolic acidosis, and the lactate levels will also get elevated. Okay, so the patient will be having signs of hypovolemia because of lot of fluid loss from the diarrhea as well as vomiting, and maybe sometimes because of the GI bleed. Then the patient will be having increased metabolic acidosis with high lactates. Now this metabolic acidosis is usually high anion gap metabolic acidosis. Alright. Now, does all patients progress into stage 2? No. Sometimes if only mild intoxication has happened, the patient can very well recover from stage 1. In that case, the ABG will be normal. The patient will not be having metabolic acidosis. There won't be any hemodynamic compromise. But here, in this case, if the patient goes into the stage 2, patient will be having hemodynamic compromise. So there will be increased heart rate, tachycardia will be there, and the BP might come down. Alright, so that's very important. Now, stage 3 usually happens after 24 hours. So this is stage 2 up to 26 to 24 hours. Now, stage 3 is when the patient will be having coagulopathy and all the bleeding manifestations due to that. Okay. Now, stage 4, the patient goes into hepatic failure. Okay. It doesn't mean that all patients will go into hepatic failure. I'm saying the worst of the worst case scenarios, like in our first patient. Okay. So, patient will be having encephalopathy because of hepatic failure. Encephalopathy. And the patient will be having coagulopathy again because of hepatic failure. Okay, so this is fulminant hepatic failure. Now you can see there are 2 stages where coagulopathy is predominating here. Okay, but in stage 3, mostly the coagulopathy is because of the inhibition of the cofactors involved in the coagulation pathway, and in stage 4 it is because of the decreased production of cofactors from the liver. Alright, now stage 5, this is the last stage where the patient can have further complications. See, if the patient survives all the initial 4 stages, then the patient can have delayed complications after many days or few weeks later. Okay, this is because again of the local erosion caused by the corrosive iron here. Alright, it can result in gastric scarring, which can result in pyloric, stenosis and bowel obstructions there. Okay, so those are the 5 stages. Stage 1 is mainly GI. Stage 2, the patient will be having metabolic acidosis and elevated lactate, altered hemodynamic parameters. In stage 3, the patient will be having coagulopathy. Stage 4 is fulminant hepatic failure, and stage 5 is very much delayed complications. Usually we do not see that in the emergency department or in the ICU. After the patient has been shifted to the ward, or even after discharging the patient might come back because of stage 5 complications. Okay, I hope the clinical features and the stages are clear. But practically, we basically divide into 2 stages. Stage of initial presentation with GI symptoms and the stage of metabolic acidosis and hemodynamic compromise. Alright, because that's more important to us when we are managing the patient in the emergency department as well as in the ICU. Now, how do we diagnose iron toxicity? Alright, of course, it's a clinical diagnosis. We need to get that history of ingestion of iron tablets, but sometimes this history may not be available. Let's assume that if the history is available, then we will need to find out how much tablets the patient has taken and what preparation she has taken, so that we need to calculate the toxic dose, whether she has taken the toxic dose or not. Alright. Okay, now what are the other investigations which we need to do? Of course, we have already mentioned that the patient can have bleeding, so we have to do a complete blood count. Especially we need to know about the hemoglobin part. Okay, in the first case you can see that the total count was elevated. This is a usual stress response seen in most of these patients. Alright, so if the history of ingestion is not there, we might get confused whether we are dealing with sepsis or not. Okay, it could be because of acute gastroenteritis. We might get misled by that kind of information as well as the elevated total counts here. Okay, then of course we need to perform renal function test, liver function test, coagulation profile. It's very important. Coagulation profile, including your APT, APTT, INR. Yeah. All right. Okay. Then blood gases. So VBG is usually sufficient. So you look for a high anion gap, metabolic acidosis. Then you look for lactates as well in your blood gas analysis. All right. Electrolytes are important. Okay. Then if the patient is having bleeding manifestations, always get the blood group and RH done and arrange the blood. Okay, arrange blood, it's very important if the patient is having any bleeding manifestations. Okay, and if INR is elevated, we might have to support with fresh frozen plasma as well. Okay, now is there any role for knowing the serum iron concentration? All right, it is a test which is available, although it may not be available in most of our hospitals. Many of the labs might be doing that. All right, but it's going to take some time. So most of our decision making and management will be based on the clinical parameters as well as the ABG. All right, ABG as well as the coagulation parameters. We cannot mostly rely on the serum iron concentration. So if you remember in our first case, okay, in our first case I have mentioned the serum iron level which we had sent to a different lab and which we got many hours. I think it took almost a day to get back the result, and you can see that was even within the normal range here. Okay, so we also did a total iron binding capacity which is also again within the normal range. Alright, so the learning point here is that you cannot rely on the serum iron concentration. Of course, if you can get it very early, like after 4 hours, within 4 hours, iron will reach a steady state in the plasma within 4 hours. So if you can get a level at 4 hours itself, and if it is very much elevated, it suggests of severe toxicity. Alright. For example, if it is more than 500 microgram per deciliter, you can see here, if it is more than 500 microgram per deciliter, it is suggestive of severe toxicity. But even if it is within the normal range, you cannot rule out iron toxicity. Alright. Now what about total iron binding capacity? It has no role for evaluation of iron toxicity. It might be normal, it might be elevated, but it has no use in the management of a patient with iron toxicity. I hope that's clear. Alright. Now, coming to the management part. Of course, for any toxicological case, the most important management part is going to be supportive care. So let's deal with treatment here. Supportive care and managing the airway, breathing and circulation. Okay, so if the patient is not maintaining the airway, if the patient is critically ill, you need to consider intubating this patient. Alright, if the patient is having signs of respiratory failure, you need to consider putting the patient on mechanical ventilation. Alright, now if the patient is having signs of hemodynamic compromise, that is elevated heart rate, the blood pressure is towards the lower side, you need to put 2 large bore IV cannulas on this patient. You might have to give fluids to see the response, and if the patient is not responding to fluids, you might have to even start the patient on pressors. Okay, now after that, one of the most important thing is decontamination. Okay. Now, what are the decontamination agents we know of, or the decontamination methods we know of? One is gastric lavage. So in our patients, the first patient presented to us after 24 hours, there is no role for gastric lavage. The second patient presented after 4 hours. Again, there is no role for gastric lavage because we know that it has to be done within the first hour. Alright. Otherwise, the patient should have taken some kind of extended release preparation, so the drug might still be within the stomach there. Okay. Now, is there any role for activated charcoal? Activated charcoal, we know it doesn't bind to metals. So activated charcoal is also useless in iron toxicity here. Then what is our option? Is there any role for whole bowel irrigation?